Hello. So this PowerPoint is going to be discussing non-surgical periodontal therapy. But before I get into the PowerPoint, I'd like you to look at your week 2, in your week 2 Moodle shell. And I discussed this last week that when I return next week, we're going to review a care plan for a more complex case. So you'll see that there is a practice case for a client with periodontitis and an appointment plan template. So after you review both of the PowerPoints, I'd like you to attempt to create an appointment plan for this case, and we'll take it up next week when I come in. So, non-surgical periodontal therapy. This is what we perform on a regular basis as dental hygienists. And when you're going to create an appointment plan for a client who has periodontitis, it's really the same concept as a client who's a DD1. It's just going to be a little bit more complex, a little bit more lengthy. There's going to be more appointments involved. We're still going to identify the human needs deficits as we go through our assessment phase. We're going to identify the client's problems. And when we identify those problems, we're going to attach those problems to a human needs deficit, determine what they are, and create interventions to deal with those deficits. So what we're looking for throughout our assessments are our signs and our symptoms. So your signs are disease that are observed and measured by you, the clinician. Things like bleeding upon probing, what does the gingiva look like, evidence of pockets, furcations. Those are all things that we see as clinicians, and those are signs. Symptoms of the disease are noted by your patient. They may have soreness upon chewing, they may have loose teeth, they may have halitosis. But for some clients, they may not notice any symptoms at all yet, that the disease hasn't advanced or progressed as far. So we're going through our assessments all the way from the health history to the extraoral, the intraoral, the hard tissue, the habits, our periodontal gingival assessment, and we're looking for those signs, what we're observing. And we're going to attach those to a human needs deficit. So you can see in this slide where the information that we've gathered, we've applied to a human needs deficit, and we're going to circle those areas. And now we know what deficits this client is facing. And you can see by looking at the slide that they have deficit from box 1, 5, 6, 7, and 8. So now we know we have to create interventions, goals for the client. With the client, you're going to create a goal to address these deficits, and then you're going to plan the interventions that are going to treat these deficits and hopefully eliminate them. So let's look at the first one, unmet human need for protection from health risks. So when we're doing this, the first thing we want to look at is, what is it due to? So why do they have this human needs deficit? Well, it's due to the potential risk for a medical emergency. That's why they have the deficit. And how do we know that? What is it evidenced by? Well, it's evidenced by that they have type 2 diabetes, that they have an A1C of 7.5 that was just diagnosed 4 months earlier, and that they have hypertension diagnosed 2 years earlier. So we know that the human need deficit is due to potential risk for a medical emergency, and it's shown by the signs and symptoms of what their condition is. So what could be a goal for this? Well, a client goal for this could be making sure that they're taking their medications on a regular basis as prescribed, that they're following the proper diet, and that they're indicating to you any changes in their health at each appointment. What could be an intervention for you to help address this deficit? It could be that you're going to educate them on the importance of taking their medications, of eating nutritious meals, and again, of reporting changes in their health to reduce any chance of there being a medical emergency when they see you, so that you're aware of what's happening. So let's look at this one, unmet human need for skin and mucous membrane integrity of the head and neck. So what is it due to? Why do they have this deficit? Well, they have it because there's supra and subgingival biofilm present. There's extrinsic staining, there's calculus, that there's an immune response to type 2 diabetes, and they have high blood pressure, right? So why do they have this? Because it's due to these factors. And what is it evidenced by? What are the signs and symptoms that we see? Well, we see that they have stage 3 grade C periodontitis, that they have radiographic bone loss, that they have probing depths of 4 to 6 millimeters, that they have horizontal bone loss showing on the radiographs, that they have a bleeding index. So these are the signs and symptoms that are defining why they have these human needs, unmet human need. So what could be a client goal? So when you're thinking of client goals, think about things that you want to improve in the client's health. Not just that they're going to verbalize that they understand periodontitis by the end of the appointment, but that there's actual changes going to occur, that things are going to improve, so that if there's pocket depths, maybe we can reduce those pocket depths by a millimeter. If there's bleeding upon probing, maybe we can reduce the amount of bleeding upon probing. Those are the type of goals that you want to work with your client on and have them to obtain. Why? Because we want optimal oral health. So once we know the goals, we know there's a deficit, then we have to plan the interventions on how we're going to treat that deficit. That's what we're doing. So if we have biofilm and calculus present, we want to have instrumentation to remove that biofilm and calculus. Maybe we have to have local anesthetic to assist with pain control. We want to introduce, obviously, self-care and reinforce it and review it with them. We want to maybe have a 4 to 6 week re-eval. So these are some of the interventions that you're going to use to target those signs and symptoms. You're going to target those etiologies. So again, always think about the signs and symptoms that you're seeing throughout your assessment to help determine what interventions you're going to use to treat those human needs deficits. So let's break it down in reverse. We have a human need for responsibility for oral health, right? How do we know this? We know this because they're brushing twice a day. The client has verbalized that they're brushing twice a day with medium bristle brush, that they're only flossing 2 to 3 times a week, that they have a PI score of 85%, that the client has told you that their last dental appointment was 4 years ago, that it wasn't a cultural norm for them to see a dentist, but they're motivated to improve their oral health. And so what does it due to? Why do they have an unmet need for responsibility for oral health? Because they have inadequate oral self-care at home. They're not looking after the teeth. They're not seeing a dentist on a regular basis. They're not having regular preventive oral health throughout their life. So again, when you're looking at your human needs deficits, you want to think about what is causing it. What's the etiology of it? Inadequate oral self-care, lack of preventive oral health care throughout their life. How do we know this? Because we have signs and symptoms that we've discovered throughout our assessments. We have a PIGI score of 85%. We have flossing of 2 to 3 times a week. We know their last dental appointment was 4 years ago. So that's our evidence, right? Our signs and symptoms are our evidence. The etiology is what is causing this human needs deficit. So let's think about some etiologies for periodontitis. Again, we're going to review that entire assessment to complete our problem list. We're going to go through the health history. Are they a diabetic? Could they have a condition that's related to periodontal disease? We're going to look at their dental history. How often do they see a hygienist? How often do they have preventive maintenance? When was the last time they saw a dentist? We're going to look at their nutritional profile. Are they deficient in fruits and vegetables and vitamins that are going to help support their periodontium? Do they have bleeding upon probing? What is their bleeding upon probing? We're looking at the extra and intraoral. Do they have lesions? Do they have improper placement of frenums? Is there something going on in the mouth that is affecting their periodontium? We're going to look at the hard tissue. Do they have overhangs? Are they missing teeth? Do they have over-eruption teeth that are over erupted. Obviously, we're going to look at perioginge, we're going to determine their CAL, we're going to look at the condition of the gingiva, and we're going to use radiographs as well. We're going to look for that bone loss if there's any evidence of it. And when we go through all of these assessments, it's from there that we can start to attach them, the signs and symptoms, right? What we're seeing, what a client is explaining to us, and we're going to attach them and create that problem list and determine what deficit, what human need deficit they have. So this could be some of their problem lists. Calculus and plaque, stain, bleeding upon probing, CAL mobilities, FERCAs, recession, and any other risk factors. So you're going to take those problems and you're going to circle them in the appropriate spot under the human needs. So now we have to care plan for our chronic perio patient. And studies have shown that they're going to be more successful when it's a combination of the mechanical removal of deposits, so what you're doing, and focusing on OHE and what the client is doing to remove those deposits at home. And usually they'll respond predictably. If it's not too advanced case for early to moderate treatment, the focus on the removal of the deposits and oral self-care education at home usually gets a good response with our clients. As a disease gets more aggressive or more advanced, it may not respond quite so predictably. Just traditional non-surgical periodontal therapy and oral self-care at home might not be enough. We may have to include things like chemotherapy, which are known as host modulation agents like doxycycline, which they'll take, maybe biological testing, so they can actually test to see what bacterial plaque is underneath there, what's happening. It may referral to an MD, to a doctor for a reason. Maybe we're looking at potentially undiagnosed diabetes. Again, because the host will respond to a specific periopathogen, and if we're doing everything we can to mechanically remove the deposits and they're still responding, something else is going on, right? That it's not the presence of calculus and plaque that's not there. So they should have responded, they're not. So why aren't they responding? And we have to take those additional steps. So common interventions when we're looking at non-surgical periodontal therapy is radiographs, starting with them, full mouth series. They help us with our diagnosis. They help us locate calculus underneath the gums. They help look at other things like overhangs, and I'll get into that in a minute. Sometimes we need to involve pain control to make the client more comfortable when we are doing the mechanical debridement, when we're removing that calculus and biofilm. Obviously instrumentation, that's a big part of it. We have to get in and remove it. Stain removal, if there is a lot of stain, it does make surfaces smoother. Obviously OHE, OHI, if a client isn't educated and isn't doing a good self-care at home, they're not going to respond as well. Desensitization. If you look at these two images, you can see all the calculus in the upper image, and once it removed, you can see that recession that is now present, the root of the tooth that is exposed, and they may experience sensitivity in there, and we may be required to apply a fluoride varnish to help with that sensitivity. And it may involve a referral. If the case is too advanced, if they're not responding, that may be our next step. So obviously radiographs are really important if we can get them to help support our diagnosis, to help get a very accurate image of what's happening below the gum line, because we can't see below the gum line. So traditionally will request a full mouth series. So you're going to take 4 bite wings. You're going to take 2 posterior bite wings and 2 premolar bite wings, and then you're going to take 2, 4, 6, 8, 14 PAs. right? So that we capture all the teeth and all of the areas, and we can fully see what's happening, the apices of the teeth. We can see where the bone levels are. Sometimes the dentist will also prescribe what we call a vertical bite wing. So you can see, if you look in the picture above, these are horizontal bite wings, and now we flip the film and we get a vertical bite wing. So what it lets us see is interproximally, like a regular bite wing, but we also get to see the bone levels, unlike our traditional bite wings above. And it's really important that your client understands why we need to get those radiographs and the amount that we're taking, because it is a lot of radiographs. So you have to be able to explain to them that it's going to help us confirm our diagnosis, that it's going to let us see the bone levels, which is so important to know that. Is there horizontal bone loss? Is there vertical bone loss? It's going to let us see the presence of calculus, which is going to help us be able to debride that area more accurately. It's going to confirm if the presence or absence of caries, right? We're going to look at that. That could be an issue that could be causing periodontal disease. It's going to let us see impacted teeth, overhangs. Again, if there's an overhang, there's usually food impaction. It contributes to bone loss, to inflammation. So radiographs help us to see that and help treat it. And it's really important that clients understand that we can't confirm our findings without radiographs, that we can forward those radiographs to their dentist, that's not a problem, and that the exposure to radiation really is minimal. We do put a lead apron. In modern x-rays today, the radiation dose is very small. Eating a banana exposes you from natural radiation from potassium. So one dental x-ray is roughly the same amount as eating a few bananas. A few minutes of sunlight, you'll get more radiation than a dental x-ray. A short flight will expose you to several times more radiation than a complete set of dental x-rays. So today, with our digital radiography systems, exposure is reduced up to 90%. And at Cameron, we also follow the ALARA, well, any healthcare provider should follow the ALARA principle, which means we take x-rays only when they're clinically necessary, not routinely. So these are things that you need to know and understand and be able to explain to your client if they have concerns about getting radiographs and why we need to take them. So OHE, OHI, obviously we need to focus on that with our periodontal client, with all clients, but with our periodontal client, like I said in previous slides, studies show that we get good results when good at-home self-care is combined with mechanical removal of the biofilm by us. So what you want to do when you're thinking about your OHI for your clients is base it on the disease state and diagnosis, okay, on the worst condition. What do we need to treat and how do we need to treat it? You need to understand your client's knowledge base. Are they very knowledgeable? Do they not have any knowledge about the situation, about periodontal disease, about gingivitis? Do they understand it? Are they motivated? What will motivate them? I'm going to tell you that if a client says to me that they are never going to floss, doesn't matter if I show them 10 times, they're never going to do it, then I'm probably not going to recommend that. I'm probably going to look at other interdental aids that they will be motivated to use, that will encourage them. Are they going to be motivated if their breath smells better, if they have less bleeding, if their gums look more attractive? What is important to them? You want to sequence your oral health aids. So sometimes we don't always want to introduce aids right away. Especially with periodontal clients. Things like in proxy brushes or rubber tips, we want to hold off introducing to our clients until the last appointment. And the reason being, if we start too soon and they use it in the whole mouth, but those areas haven't been debrided by you, the tissues can start to tighten up. And then it just makes it more difficult for you to go in to do your scaling. So we want to wait until all of our treatment is completed. So usually those type of aids are introduced later on, the last appointment. And things are scaffolded. You want to build upon the knowledge. Sometimes giving them too much knowledge at once can be overwhelming. So you want to sequence it throughout your appointment plan. You want to review it right? At every appointment, we know that as soon as we teach OHI, the next appointment, we're going to do our PIGI, our indices again, and we're going to review that oral hygiene instruction with them. How is it going? What works for them? What isn't working for them? Is there an area that they're missing? And do we need to modify them? You also want to talk about nutritional counseling and smoking cessation. Is it something they're interested in? How can you support them with that? That is part of our role, and an important part of our role. Have they changed their diet that you recommended and that you talked about? Watch recommendations that you talked about. So, as mentioned before, gingivitis in last class is reversible. Periodontitis is not. It's a chronic infectious disease. And it's really important for the prevention and successful treatment of it is that it's a co-therapy approach, that you're working as a team with your patient. So you're doing your end of things with the mechanical debridement, but they're doing their end by adequate oral self-care and complying with the treatment that you're recommending. And that's how we're going to get the best result and maintain optimum oral health. Sometimes we have to look at pain control, and it could be because the client is in actual pain. They have a lot of inflammation, they have recession, they're very sensitive, or are they just anxious? And you want to kind of look at that and help that to determine what you're going to do or not do for them. Some clients do have a low pain threshold, and that's just the way it is, or they're very anxious. So the more a client is comfortable or a patient's comfortable, the more you're confident you are. When someone is moving around on you and jumping and uncomfortable, you start to pull back, and it really impacts the ability of the hygienist to do the best job they can do. So what can we do for them? Is it just a case of applying some desensitizing agents after rescaled to help manage some discomfort, right? If you think back to that slide a couple slides ago, when all the calculus was removed, you could see the areas of recession. The client might experience some sensitivity. Is it topical anesthetic, something like Oroquix or Cytocaine? Will that work for them? If it's just more soft tissue and we apply a little bit of topical and they're more comfortable and it's easier for us to access. Is it to the point where they're very nervous, they're very sensitive, you can't get the instruments subgingivally, you just can't apply any pressure, that we have to ask the dentist to work with us and apply some local anesthetic for them? We have to give them some medication? Do we have a really anxious client that may need to have some medication to be a little bit more calm in the chair? So these are questions that we have to work with and ask our clients to make them comfortable so that we can do the best job that we can for them. So desensitizing. Duraflor is what we have in our clinic. There are a lot of different types of fluoride varnishes out there. So what I recommend when you get out into practice, that you read up on each one. Sometimes they're used differently, they have different post-op instructions, but they're very, very effective for clients who have recession or abrasion. They're very easy to apply. You're going to wipe the tooth dry. You're not going to use air, because if someone is sensitive and you use air, they're probably going to jump out of the chair. So you just take a gauze, you wipe it dry. You're going to show the client the area that you're going to apply it. You're going to apply it with the brush. You're going to ask them not to brush it up. Typically, I think it's 2 or 3 hours, and don't eat anything hot or crunchy. And then you want to make sure that you're going to document that in your record of treatment. You're going to document what product you use. So in this case, it's Duraflor Ultra, what flavor is it, and the areas that you applied it. So I applied it to the buccal of the mandibular anteriors and the buccal of the maxillary sixes. And that's what you want to document in your record of treatment. Other things we're looking at when we're going to decide if we need to use anesthetic with the client, we're looking at pocket depths. Do they have pocket depths greater than 4 millimeters? Are we having to really, extend? We're 6-7 millimeters. We're down there quite far. What's the pockets like? Is it difficult access to it? Are there furcations? What's the tissue tone? Generally, clients who have loose tissues and it's easy to get the instruments in are more comfortable. When they have tighter tissues, and that happens, and especially sometimes with smokers, they don't look like your typical periodontal client. The tissues almost look healthy and they're tighter, and it's harder to get instruments down there, and they might have more sensitivity. But in reverse, if there's lots of inflammation, they can be very, very sensitive. Their tissues, you touch them and they're very sensitive. Could there be lots of bleeding going on? So client-related factors, what's their pain threshold like? How sensitive are they? And that's just the reality. Some people have a very high pain threshold, some don't. You want them to be nice and comfortable when you're treating them. It just makes it more effective and easier for everybody. So local anesthetic, very effective, right? The dentist is going to prescribe that or provide that for us. At this time in Ontario, we can't. Fingers crossed it'll come soon. But it's very effective. Usually it's for quadrant scaling. Generally, you won't freeze more than half a mouth. And when you do it, usually you want to do the same side of the mouth so they can eat on the other side. It's very important that you review notes and that you set it up. So you will set it up for the dentist in the clinic, but make sure that they know what areas that they're going to go in and apply the local anesthetic. I will tell you that it has happened that a dentist went in and applied or gave local in the wrong area for a client one time because they didn't listen to or didn't follow what I had said. They didn't read the notes. Yeah, nobody was happy. So you don't want that to happen. So you make sure that everyone knows where local is going to be applied. Topical anesthetic, it's usually not effective for deep perioscaling. I will tell you that I've had some success with Oraquix on clients who had more soft tissue, a little bit more inflammation, no root sensitivity per se. It was more their gums were inflamed. It has worked well, but the deeper the pockets you go, generally topical anesthetics aren't as effective. You need to go into local. You do have to use it sparingly. So there are guidelines of how much you should be applying. There is a higher rate of allergic reactions, and it's short acting. It doesn't really last very long. The Oraquix maybe 20 minutes, so you kind of want to apply it to 2 or 3 teeth, debride those areas, apply it to the next 2 or 3 teeth, debride those areas. You wouldn't apply it to a whole quadrant because by the time you got up to the last few teeth of that quadrant, it's probably starting to come out. And again, use sparingly. So there is a limit on how much you can use. So there are some benefits, but there are side effects, some cons to using it. So now we're going to go on to our instrumentation. That's what we're there for, right? The mechanical debridement. What are we going to do? So as you're making your treatment plan, you're going to determine what types of instrumentation are you going to use. Are you just going to use hand scaling? Or are you going to use an ultrasonic? Instruments of choice. What type of instrument are you going to use? Are you going to use Gracies? Are you going to use universals? Sequencing. So again, what sextants are you starting in? Are you doing sextants or quadrant scaling? I will say I would recommend that as you set up your treatment plan, pick the worst areas. Okay, don't start in the easiest areas. And I know a lot of us, you're like me, the fourth quad is really nice to start on, but you want to pick the areas that are not harder, but maybe have deeper pockets, have more buildup, so that you address those areas first and you have time to reassess those areas throughout the treatment of your client. Don't leave the hard areas right to the end. You have to make sure you document the time spent scaling in your record of treatment. So in units, if you spent 3 units, that's 45 minutes. If you spent 4 units, that's an hour, right? So 15 minutes intervals is units and how much time you spent. And again, when you're scaling, you really should be planning on the scope of practice and the experience of the DH. So the more complex a case gets, if it's difficult access, if there's a lot of furcation involvement, if there's very, very deep pockets, maybe that's beyond your scope. And even as an experienced hygienist, and you might want to think, now's the time to refer out to a periodontist. It's really important as a hygienist that we stay abreast of the most recent developments in tools that we can use out there, new tools, things like the airflow machine and the new ultrasonics. But before you use these new tools, you really have to evaluate if they're effective through clinical and evidence-based decision making. Is it right, or should we stick with tried and true? Stain removal, it could be part of your treatment plan if there's a lot of stain. Remember, you have to explain to the client the contraindications for it. Is there contraindications with the client? Do they have asthma? Is coronal polishing something that you should not be doing on that client? How does the client feel about it? I will say a lot of people associate it with dental cleanings. They just assume they're getting a coronal polish. Some clients hate it, but some people feel their teeth haven't been quote unquote cleaned unless they've been polished. But remember, there's no therapeutic benefit to it. So if there's no stain, there's no reason to be doing a coronal polish. You can use ultrasonics and hand scalers to remove that biofilm. Most often it's a selective polish. Generalized polishes are few and far between. In the old days, that was something we did. We polished every single tooth. We don't do that anymore. If there's no stain, there's no need to polish that tooth. Again, sometimes stain removal can be done just by hand scaling and ultrasonics or air polishers. We don't need to get into that coronal polish. If you do a coronal polish, you have to determine the type of grit. Is it fine? Is it medium? And if you start with medium, you should be finishing with fine. The important thing with coronal polish, though, when you're doing it on a client that you're a more complex client, a periodontal client, and we're doing quadrant scalings, we want to wait to do it until after gingival healing. If those tissues are really inflamed and you're getting in there with grit, it's going to get into those pockets and just can make it worse. Not heal as well. So we want to wait till those tissues have healed before we get in and do a coronal polish. Other supportive therapy that we may want to include in our treatment plan are things like topical fluoride, if there's areas of recession, if there's sensitivity, if we have done a coronal polish. Do these clients need sealants? Are there areas of demineralization that we want to apply a sealant to hopefully stop it? Would we recommend that they see a dentist for a night guard? Are they grinding? Are they clenching? Is there occlusal trauma going on? Do we want oral irrigation to go in and flush? And I'm going to say ultrasonics are great for that because there's that part of using an ultrasonic, the lavage, that will go in and help remove that biofilm. Removal of plaque retentive factors. Are there overhangs? Are there old restorations that a dentist needs to go in and remove that restoration and get rid of that overhang? Do we have to recommend chemotherapeutic agents like the doxycycline that I talked about before, that is prescribed that we can either give topically or can be delivered locally? Do they need surgical intervention? Is a referral to a periodontist required? That the standard mechanical debridement non-surgical periodontal therapy is not enough. Just us going in and scaling isn't, the client's not responding. They need to take that next step. And do we need medical intervention? Do we suspect undiagnosed diabetes? And that we're recommending that they see a doctor to be tested for it. So these are things that, again, you have to factor into your treatment plan. So historically, and this is how I learned when I first started working, this is how we treated clients who were more complex. We did what we called a gross scaling. So the first appointment, we took our ultrasonics, we got rid of any supracalculus, any big chunks above the gum line, and we stopped. And that's all we did in that appointment. And we did the entire mouth. So we wouldn't have had the time to ultrasonic the entire mouth and then hand scale it. We had the client return for their next appointment, and then we went down and scaled and attempted to remove the remaining deposits. And they called it circuit scaling, and it was kind of whittling away at the calculus at every appointment. But studies have shown that this is not the recommended way to remove calculus, and there's reasons for that. When you go in and at the first appointment just with an ultrasonic and try to remove calculus and deposits are left behind, they're rough. And when they're rough, the biofilm, which consistently builds up all the time on someone, so you see it's a week before you see that client again, now they have buildup attached to those rough areas of deposits, and it's going to make it that much harder, and things are not going to respond. Also, because we have removed deposits, there will be some response of tissues. They're going to shrink, and they can close off the pockets, which could lead to an abscess forming. And now we have the dentist has to intervene. Also, as that tissue shrinks down, it gets harder to insert our instruments. The client's more uncomfortable. It's more difficult for us to do our job. And the client gets frustrated. They don't understand, why are you quote unquote cleaning, right? Why are you back in that area again? Didn't you just do this last time? It can cause frustration from the client's perspective. They don't understand why there's multiple appointments when it seems like you're doing the same thing over and over again. So that was what traditionally we do. That's not what we do anymore. The gold standard of care now is we only start what we can finish. So you need to be aware of that moving forward in the next semesters. You may schedule or create your treatment plan, and you're going to start with quadrant scaling. If you have some time left in your appointment, your instructor may say, okay, let's take 2 teeth and we're going to do 2 teeth. That's it, that's all. So whatever you start to treat, if you're going to ultrasonic, you have to hand scale, and you've got to complete. We don't ultrasonic and not hand scale those areas. So you have to determine how many teeth can be completed in that appointment. And it could be just a few teeth. It could be 1 section or 1 quadrant. It could be 2 quadrants on the same side of the mouth, right? And that's where you're going to work with your instructor, determine the treatment plan, and how you're going to schedule out your scaling appointments. And this is why when I said in the last class, there's no way you can complete a complex client in 1 appointment and effectively remove all of that calculus. So it is, if you're going to complete a maxillomandibular quadrant, it's better to do 1 side of the mouth. It's that way your client has the other side to chew on, that it divides the work more evenly, and especially if you're going to be using local anesthetic, the dentist will only want to apply local anesthetic to 1 side of the mouth. Instrument selection. So what are we going to use? Ultrasonics, universals, rigids, regular Gracies. What are we doing? Again, your rigid Gracies are what I'm going to start with, and your regular Gracies are more flexible. They're more for root planing and fine scaling. And you're going to use them in this order. You're going to start with your ultrasonics. You're going to go in with your universals and help remove anything that's supra. And then you're going to start to go sub with your rigid Gracies to get rid of those moderate and heavy deposits, and finish off with your regular Gracies to smooth out those root surfaces. Your regular Gracies just are, the shanks aren't rigid enough. They won't withstand the pressure of moderate to heavy deposits and trying to remove them. So you're frustrated the calculus isn't coming off. Why isn't it coming off? So don't be too hard on yourselves, right? You're just learning. Remember, you're just going in to see your 3rd client. So if it's not coming off, sit back and reflect. What's happening? Is it your technique? Are they dull instruments? And this is really important. Okay, dull instruments make you work harder, and they won't have that edge to get under and remove that calculus. Are you tired? So seek help. Okay, look to your instructors. Get them in to help and look at what you're doing. Don't be afraid while you're scaling to ask an instructor to come in and sit with you and watch what you're doing. That's how you're going to learn. So think about things. If you find you're going in and you're scaling an area and you check with the Explorer and nothing seems to be coming off, what's happening? Are you inserting subgingivally? And usually that's the biggest thing when I go in and watch a student, they're not inserting, or they're not inserting at the line angle. So practice your insertion. Go slowly. Rest the tip against the side of the tooth and slowly sink it sub. Okay, you don't have to rush. A client can't see what you're doing. Take your time and make sure you're inserting sub. Do you have too tight of a grasp? If you have too tight of a grasp, you're not going to be effective. Remember that TAR principle. Tighten, activate, release. Strokes. Are you doing long strokes and not overlapping? And that's another one of the biggest things I see when I watch students scale. When I go in to scale a surface, I'm scaling the mesial of the 4-6 on the buccal. I'm going to insert at that line angle. It may take me 30 strokes to get all the way interproximal. Not 4, 30. So what I'm going to do is I'm going to insert subgingivally to the bottom of the sulcus, and I'm going to take, 4 strokes back up towards the gingival margin. Advance my instrument, go back down to the bottom of the sulcus, take 4 or 5 strokes up towards the gingival margin. Move forward, bring my instrument back down to the bottom of the sulcus. I'm using overlapping strokes. It's hard work. It takes time and strength. 4 strokes from line angle to interproximate is not going to be effective enough to remove calculus. Are you using the wrong instrument of choice? Do you have a 5mm pocket and you have the 204S that just can't get down there deep enough? Do you have a 2mm pocket and you're trying to remove it with a 15-16 Gracie? So think about the instrument you're using. Make sure you're using the right instrument for the right area. Sharpen, sharpen, sharpen. It makes all the difference. And yes, you're going to have to sharpen before. We do not sharpen chair side. We're not allowed to sharpen chair side. So don't be afraid to seek out help from your instructors. If you don't have a client, that's one of the things you can do in clinic, is take your instruments and sharpen. Remember that you have to get them reprocessed. It probably takes up about 2 days once you hand them in to be reprocessed, and then they have to quarantine for 24 hours, so be aware of that. Know when your clinic time is coming. And it is a learned skill, like every other skill that you're learning. It takes time, but sharp instruments will heighten your detection, make your job easier, and you won't become as fatigued. So it's really important that you keep your instrument sharp. It's hard work. It really is hard work. You get better the more you do it, like anything else. So realize your limitations. Don't be afraid, like I said, to seek feedback from your instructors. That's what they're there for. If you see an instructor that doesn't have to see another student, isn't in doing an assessment, isn't taking radiographs, ask them to sit with you, ask them to watch you, and go back to the basics. Get out your textbooks, take a look at it, read it, and practice what you're doing. If you have time and want to hop in the sim lab, let us know. You can go in there and practice your instrumentation in there and get comfortable with it, especially if you're uncomfortable with it inserting. Go and practice. When you're scaling, you should be referring to your assessment data at all times. You should have your periodontal probing up. You should know where the pockets are. You should know if there's a furcation there. You also should be looking at your radiographs. Where is the calculus? What are we looking at? Is it vertical bone loss? Is it horizontal bone loss? What does that pocket look like? So you should have that information up at all times when you're scaling. So let's take a look at an example care plan. And again, we want to use our radiographs. Where do we start scaling? So we want to look at the type of bone loss. Again, when we look at this, is it vertical? Is it horizontal? Where is the calculus? Are there overhangs there that we need to be aware of? So we've determined and we've created a care plan, we now have to present it to our client, right? We have to get that informed consent. There's our legal responsibility, but it's also a way to encourage collaboration between you and your client. You want to work as a team. You want them to be fully aware of the situation in their mouth and to take an active role in it. It's important that your client understands that there's a difference between an advanced case that they might be and what it's going to involve, and that for the long-term benefits, they need to have more treatment, that they need to have regular evaluations, and that the extensive nature of their periodontal debridement and the number of appointments that is needed is what's involved to get them healthy. So when you're presenting to your client, and we've talked about this before, I know, use layman terminology. Keep it simple. Okay, when you're explaining your assessment findings. If you start using CAL and MAG, you've lost your client. They don't know those words. You didn't know those words until you started the program, so they're not going to know those words. So think about using tartar, bone loss, those type of terminologies. Again, present it to your client, chart page by page. Go through each of one of the assessments and discuss it with them. Use the radiographs. Bring them up, show them. Let them see the bone loss. Let them see the calculus. It's going to help them understand. A picture's worth 1,000 words. And make sure you have a check problem list, right? That you've covered all of the areas to talk to them about. All those signs and symptoms that you found during your assessment, right? That you've determined their human needs deficits. You need to talk to them about that in your case presentation. It's a lot, but you want to try to keep it to 5 to 10 minutes. Okay, you don't want to sit there and read it to them. You need to prepare ahead of time. You need to be aware of what your treatment plan is going to be and talk to them. Look them in the eye. Don't sit there and read it. You start to go into 15, 20 minutes and your clients aren't listening to you anymore. They're thinking about, what am I going to make for dinner tonight? What do I have to do after I leave here? So keep it not quick. You have to cover all the bases. You have to make them understand, but think about what you're saying to them. Again, yes, you're going to go into OHUHI, but don't turn your case presentation into OHUHI. Don't go into depth explaining what plaque and calculus is, and brushing and modified Stillmans. That's what you're going to do over in the oral hygiene area. So some examples, right? Now that we've completed a very thorough examination of your teeth and gums, I'd like to take a moment and review your findings. That's what you want to do. And then you're going to go through your findings. Was there something in the health history, like diabetes, that you need to talk about? Is there bone loss present? Is there calculus present? Is there bleeding upon probing? These are the things that you want to talk to them about. You could say, in reviewing your health history, you're generally in good health, but it's important that we continue to monitor your blood pressure at every visit because they have hypertension, because they're on medication, and that's what we're going to do. Intraoral, I checked your tissues in your mouth. We found a red area. It's very common. They'll burn the palate of their mouth. Say to them, the dentist check it. It's not a concern, but we'll follow up at the next appointment. And you're going to continue on through all the assessments like that. You're going to talk about the indices, the PIGI. What was their score? Was it good? Was it not good? Do you think we can improve it? You're going to talk about the hard tissue. Was a dental diagnosis received? So when I say that, guys, if the dentist comes in and does your hard tissue, they received a dental diagnosis. If the dental hygienist comes in and checks your hard tissue, you have to document that the client did not receive a dental diagnosis. Okay? Just remember that. And then you're going to talk about their perioginge, and periodiagnosis is key, right? It's based only on CAL or radiographic diagnosis. So you're going to talk to your clients about that. When you After you do your case presentation, you've got consent. You're going to move over to the oral hygiene area. And you need to relate your OHI directly to your assessment findings, okay? And you can say to them, we're going to take a few minutes to review your home care before you leave today. And that's okay. Ask them what they're doing. Make sure they show you. Ask them, what type of toothbrush do you use? How often are you brushing? What type of toothpaste do you use? Show me what you do, right? You need to know that information for you then to modify what they're doing, again, to give them better tips to manage their oral care at home. Set plaques reduction goals. I talked about that a few slides back. When you want to create goals, you actually want to create a goal of something that you want to change. So if they have a PIGI of 85% or your scores are 3, set that goal right away so that the next time you see them, because remember, you're going to do the indices at every appointment, you're going to see if they're improving in that area. And if they're not, or there's still one area where you're seeing plaque, then you can adjust that, say, okay, show me what you're doing in that area because this is where we're missing. And maybe we need to modify what they're doing at home, right? You want to review the cause of periodontal disease with them and Carrie's process. You're going to use that computer to indicate it. Again, get that ready before they get into the chair. Don't keep flipping through a whole lot of slides that don't pertain to them. They'll lose interest and they'll stop listening. And please make your OHI specific to your client. Help use that big mouth model to help point to them where they have inflammation, where they have calculus buildup. Don't just generally point to the pictures on the screen. Make it specific to your client. If you want handouts, just have them reviewed prior. And again, mention to your client that we're going to introduce more topics as we proceed through your treatment. Like I said, we don't want to introduce proxy brushes and rubber tipping till we've come to our last appointment. We don't want them doing that too soon. So just say to them, I'm going to review this and we're going to introduce more topics throughout your treatment here at Cambrian. When you're talking about scaling, again, people will say cleaning. I do strongly recommend you use the word scaling, but say things like we're going to remove the tartar buildup on your teeth. Calculus, they may not know what calculus is. They're going to know what tartar is. Explain the outcomes if we don't scale, right? If they already have inflammation and they have bone loss and we don't go in and mechanically debride and remove that calculus, are we going to get any results? Are things going to improve or are they going to continue to deteriorate? They need to understand that. They need to understand why you need 3 appointments to go in to remove all the deposits to get their mouths healthy again. So really be clear with them and outline the approximate number of visits. And that's why it may take 4 visits, that we have to address each area one at a time. Explain if you're going to be using ultrasonics, if you're going to be using the airflow, hand scale. Explain each one of them and what to expect as you're using these interventions. That there is going to be bleeding, that they may have some sensitivity after because you've removed that calculus that was kind of protecting areas of recession, that you will apply varnish to help with that sensitivity, that type of thing. Again, and what are the outcomes? So like I said, especially if there's moderate to abundant deposits, they may have recession. Think back to that picture a few slides back where we could see it after we removed the calculus. So they didn't feel that before, and now it's there, and they may be sensitive to cold and to touch. And again, that's why applying fluoride varnish may be part of your treatment plan, that they're going to fill spaces. Think on that picture, there was a bridge of calculus. Now it's gone. Now they can fill in between your teeth, and you'll get a lot of clients who will say it feels funny, and they don't like that feeling because now they can feel their teeth. They may have sensitivity. They may have some mobility. That calculus may have been kind of holding those teeth in place, and that now it's gone. There may be some movement, so they may expect it. A lot of clients will say too, oh, my teeth look long, because they do have recession that they didn't see before, that now the calculus is gone, and teeth may appear longer, and that it's really important that we can use Duraflor to help with sensitivity or local anesthetic if required. So, as I said, it's really important that your client understands the state of their mouth, the degree of periodontitis that they have, and the extensive nature of periodontal debridements, and why it takes more than one appointment, and the time involved, right? So that we get that optimal outcome, that it's not one appointment. We're not doing them any service to try to complete it in one appointment. Again, help use your radiographs. Look at that calculus on these x-rays. Those are big chunks. And client can't see that. It's below their gum line. You show that to them and they're going to understand why you need to book 4 appointments. So remember, when you're getting informed consent, the number of appointments that you're going to have, the cost. We don't have a cost at Cambridge anymore. It is free. And again, that it's their right to refuse all or part of the treatment now or at any time. So they may consent initially, but they have that right to refuse that treatment later on. If they decide all of a sudden, I don't want to get fluoride, or I don't want the coronal polish, they have that right. Practice, practice, practice. I can't stress that enough. Practice with a peer, especially if you have a big case coming up and your first periodontal case. Obviously, you have to protect confidentiality, but practice with someone. Make sure that you're using layman terms, that you're not using OHE, OHI, CAL, and MAG, because the client isn't going to understand. Try to make sure you're completing it in 5 to 10 minutes, but covering all the topics that you need to cover. Practice goes a long way. Your clients will feel more confident in you if they feel you know what you're talking about, that you're not stumbling through it, that you're not having to pause and think about it, that you're humming and practice what you're saying. So be prepared. Know your client's case. Again, role playing is huge. Be organized. Use the chart as a guide, and get feedback from your instructors as often as you can. Just ask them to listen into it and give you some feedback about how you're presenting, how you're sounding. Are you saying the right things? Did you cover all of the topics? Did you talk about risks, benefits, consequences, any alternatives, right? So after we've completed our initial therapy, we do want to reevaluate. So plan for that in your appointment plan. It should be in your appointment plan as a 4 to 6 reeval. And what we're going to do is compare data, right? So we're going to go in, we're going to check to see has our treatment resulted in a response in their tissues? Are the pocket depths reduced? Is bleeding reduced? What do the gingiva look like? So when we're thinking about it and we're planning for it, this is what we're going to do at a reevaluation appointment. So the first thing we're going to do is update that health history. Always, always, always at every appointment, you're going to update that health history. Make sure there's no changes. Like we talked about before, if this client was a diabetic, one of their goals was to make sure that they understood the importance of letting us know any changes. Have they been taking their medications as prescribed? We're going to reassess, right? So we're going to do that PI and that GI. We're going to look for those plaque index. Have they been doing good at-home self-care? Have they been following what we've recommended? We're going to recheck our scaling. So we're going to go back in and see if there's any deposits remaining, and that is okay. Right? It's okay if there's some deposits remaining, especially if it's very tenacious calculus. It may not all come off at the first time. We have to go back in and rescale. We're going to complete our probing, and we're going to compare that probing. So have we had a reduction in pocket depths to 1 to 2 millimeters, like one of our goals? Did we reduce bleeding by 10%, which was one of our goals? Right? Have we achieved those goals? And then we have to decide what steps we're going to take next. Where are we going from here? So there's a decision-making process with non-surgical periodontal therapy, and we make it at the reevaluation appointment. So if you look at this graph, we have our initial periodontal assessment, where we know that this client has periodontitis. We're going to go in and do our non-surgical periodontal therapy, right? Our mechanical debridement, our oral hygiene instruction, and then we're going to have our client return. So we're going to have them return at that 4 to 6 week point, and we're going to re-eval the results of our initial therapy. So we're going to reprobe, we're going to look at the bleeding, and we have to make a decision at that point. Is the disease controlled or is it uncontrolled? And where do we want to go from there? If it's uncontrolled, and we'll get into that, what steps we're going to take. So what are we looking at with the assessment? Again, we want to go look at the probing depth measurements. We should expect some healing of 1 to 2 millimeters. We should have some reduction on bleeding upon probing. Our gingival description should change. Instead of moderate generalized redness, we should have pink. Instead of bulbous, we should have flattened, right? So these are the kind of things we want to look at. We want to look at the soft tissue assessment. It should be healthy. We want a reevaluation of the diagnosis. Again, is it successfully treated? Periodontal diagnosis, right? We talked about that last week. And then we want to plan for where we're going to go next. Do we have to do some localized periodontal debridement again? Do we need to do generalized periodontal debridement? Another appointment. Do we need to incorporate some adjunctive care, some delivery of an antibiotic, desensitized therapy, that type of thing? Do we need to refer out? What's our maintenance schedule going to be like? And we're going to reinforce that home self-care, reteach, focus on areas they're missing. Do they not like one of the interventions we recommended, an interdental aid? Are we going to think of a different one? No, I don't like the Proxa brush. Some people don't like them. They're metal. They find they're sensitive with their teeth. Okay, so that's not for you. What else can we use? What's different interdental aid can I introduce? So these are the things we want to think about at our reevaluation appointment. Because sometimes sites will be non-responsive to treatment, and again, like I said, the calculus and the biofilm is gone, but they're not responding, right? They're continuing to show attachment loss. There's inflammation there. There's bleeding upon probing. Again, the pockets get deeper. So what's going on in these areas, and what do we have to do? Again, the first thing we want to look for if we have areas that aren't responding is is the client following through on their self-care? Sometimes they're just not going to, and that's the reality. And I mean, I've had clients say, that's what I come to you for, right? I come to you to clean my teeth every 3 months, and that's what I want to have happen. That's not what you want, and hopefully you can start to motivate them over time, but you want to look at their self-care. Are they having difficulty accessing one area? Do we have to change up what we're doing with them? If there might be still calculus discovered subgingivally, so we've got to go back in and redebride that area. Again, evaluate self-care, retrain if we need, and look at other factors. Are they smokers? Is there undiagnosed diabetes? Or is there a faulty restoration? So we have to look and evaluate those areas of non-responsiveness and decide what's happening in those areas. So again, we want to look at this grid. So we've got the periodontal assessment, we've done our non-surgical therapy, we're reevaluating, and we have to decide, is it controlled or uncontrolled? And if it's controlled, then we put them on a periodontal maintenance. 3 months typically is what we're going to see them at. We don't want them to go any longer. If it's uncontrolled, if we have those unresponsive areas, what are we going to do? Are we going to book more time to do more debridement because there is calculus there? But if we've removed all that calculus, is it a case that we need to have a surgical option, that they need to see a periodontist and maybe flap surgery has to be done, different types of periodontal surgeries, and then they're placed on a periodontal maintenance from there? So there are some clinical or risk factors that will indicate patients who will benefit from a co-management with a periodontist. So generally stage 3 or 4, if you have a stage 3 or 4 client, an automatic referral to a periodontist. Again, any areas that are unresolved, that aren't responding to our mechanical therapy, intensive management of a grade B or C periodontist client. If they're diabetic, if they're a smoker, they may benefit or would benefit from a co-treatment with a periodontist. Again, clients who require surgeries that involve tissue augmentation or regeneration, if they have furcation involvements or bony defects, maybe they have to have bone removal, which is crown lengthening, maybe they have to have implants put in, maybe they have a medical history that is more involved and requires that support from a periodontist. These are type of things where, again, if a general office, if they don't feel confident, and there's nothing wrong with acknowledging that a case may be beyond your capabilities, and that's okay. That's fine. If I get a client in who's got 8-9 millimeter pockets, I'm going to refer them to a periodontist because I know that they can get in and do treatment that I can't do. And that's okay. And those are the people that we want to refer out. So this time I'd like to say questions. So think on them. If there's something that you would like me to talk about again in person, absolutely, I can go ahead and do that.